countries, and 29 registrations have come from out of India. So on behalf of
second of the presenter, Doctor, when he
Deepak sir, we are live.
Yes. So on behalf of Health and You, this is my great pleasure to welcome all the audience to this webinar of change of neurosurgical planning during COVID pandemic and endemic era. So welcome to this webinar. This webinar is coming through to you through DigiNeuro, a digital initiative by Health and You, a joint venture with Newlink Company Limited, Japan. I'll quickly introduce our products. We on only launch innovative first time in India products like amitriptyline and mecobalamin combination, AmNurite 5, 10 and 25 for diabetic neuropathy and migraine. We have AmNurite beta when one drug is not enough in migraine, amitriptyline and propranolol combination for the first time in India. AmNurite beta 520ER and 1040ER. We have AmNurite-P, where pregabalin in a sustained release form to match amitriptyline pharmacokinetic profile for severe neuropathic pain. We have mecobalamin injection imported from Japan to give you highest quality whenever you inject. We have innovative strength 2.5 milligram in clobazam to offer you a lot of flexibility and control while up titration, down titration, or BID dosing in epilepsy management. And very shortly we are launching a vitamin therapy for migraine recommended by American Academy of Neurology, which contains riboflavin 200 mg, magnesium 200 mg, and CoQ10, and that is Brentamin. I have great pleasure in now introducing Dr. Amit Kumar Ghosh, who has actually put together this webinar with all the international faculty. Dr. Amit Kumar Ghosh is also our advisory board member. He is a consultant neurosurgeon in Institute of Neurosurgery, Neurosciences, Kolkata. He is a fellow of micro neurosurgery from Fujita University, Japan. Also fellow of neuroendoscopy surgery from Karl Storz, and he has been awarded with many awards like Mother Teresa Sadbhavana Award and Indian Achievers Award for from Chikitsak Ratan. So over to you, Dr. Amit Kumar Ghosh, for carrying out this webinar. Thank you very much.
Yeah, thank you, Mr. Deepak Naik. And I have to share a slide, so I'm not going to the slide.
Yes, sir.
But Dr. Santosh, I'm fond of one of yours.
Can you see the slides?
Yes.
Yeah,
yes. We can see the slides, sir.
Yeah. So today our topic is change of neurosurgical planning during COVID pandemic and endemic era. Me, Dr. Amit, I will moderate. And first I welcome Professor Dr. Milind Deogaonkar, who is my mentor in functional neurosurgery. Sir is from Rockefeller Institute, USA, West Virginia. Sir, welcome and thank you for being here. I welcome Professor Bin Su from Huashan Hospital, Fudan University, China. Professor Bin Su, I first met in Institute of Neuroscience, Kolkata, when he came in a live surgery workshop. Professor Bin Su, welcome and thank you for being here. I welcome my senior Professor Rabi N Sahu, Professor and Head of the Department of Neurosurgery, All India Institute of Neuroscience, Bhubaneswar, India. Sir, welcome and thank you for being here. I welcome Dr. Sisir, Director and Head of the Department of Neurosurgery, AMRI Hospital, Kolkata, Unit. Sir, welcome and thank you for support and cooperation. I welcome Dr. Saumitra Sarkar, Head of the Department of Neurosurgery, Shaheed, Suhrawardy Medical College and Hospital, Dhaka, Bangladesh. Sir, thank you and welcome. I welcome you to Bangladesh. Dr.N.K, Head of the Department and Director of HealthCity Hospital, Guwahati. Welcome, sir, and thank you for your support and cooperation. I also welcome Mr. Deepak Naik and Mr. Santosh and Health and You as a whole for providing us this digital platform and technical support. Without that, it could not happen. And it is our pleasure to have you all in this difficult time. We are grateful and thankful to our speakers and discussion panelists and esteemed audiences for sharing their time and thoughts with all of us. Be safe and take care. So now we can go to Professor Milind Deogaonkar. For sir, please start your thoughts and share some knowledge with us. How should we go ahead in these difficult times in neurosurgical planning?
Can you share the screen with me?
Yes, just go to bottom and there is a screen share.
Sir, the green button, share screen.
Yeah, I see, but
Now we see you.
Sir, first you open your presentation and then go to our screen, and bottom there is a share screen.
yeah, probably.
Mr. Santosh, are you here?
Yeah. Sir, have you opened your PowerPoint presentation, sir?
Yeah, I have.
And then, sir, there is a share screen green button. Can you click that?
Yeah, the problem is I cannot see that button.
It is on the bottom screen, sir.
Sir, with your
On
cursor,
your screen.
go to bottom with your cursor.
With your cursor. Bottom screen.
No, I still cannot see it.
Go with your
It's a
cursor.
green button. It's a green one.
Yeah, I know it just.
Sir, click that.
Okay. I
Yeah.
can see it now.
Yes. Yes.
Red zone or green zone?
Sir,
You are in the red zone, probably in a red zone of COVID. That's what is not opening in the green zone.
I minimized this thing and it's just not getting maximized for some reason.
sir, can you see your presentation, sir?
I can see it, yeah. But I cannot maximize that zoom window for some reason. I minimized it and it's staying minimized.
Have you seen the share screen icon, sir, in the
No,
Zoom?
I don't see it for some reason. Okay, I found it. That's fine. I think that was minimized, so I couldn't see it. So, can you share? Can you see my screen?
We can see you, sir, but not the presentation.
Yes. Yeah, now we can see, sir. Now we can see.
Yeah.
Please put it in presentation mode, sir.
Yeah, it is
Please put it in
starting.
presentation mode. Yep. You are right.
See it now?
Yeah, ready to go, sir.
Okay. So basically, this is kind of I give these talks quite often, but Amit told me just to focus on perioperative changes in COVID-19. So I'm talking about some basic facts and basic precautions and how to use PPEs and what separately you're going to do for surgery in COVID era. And then just passing reference to what's the basic pathology in this infection. So there's some basic facts with this. It's here to stay. It's not going to go away. So it's not a stopgap arrangement. It's like a change of lifestyle for most of us who are used to dealing with patients on day in and day out basis. What's more to worry about is asymptomatic carriers. I mean, I work in COVID ICU. We do some stellate ganglion blocks. COVID ICU is probably the safest place to work in because we know these are the patients and you stay away from them. But asymptomatic carriers are the ones that are problematic as healthcare providers for us. There's no preventive treatment. There's a lot of talk going around in India about those arsenic nasal drops and camphor and hydroxy chloroquine, but there is no real preventive treatment. Vaccine hasn't yet come. We don't know when it's going to come. We don't know what's the mRNA vaccine is going to look like. We don't know what kind of preventive antibodies it's going to generate. So we still have to change some of our working habits for next 2 years to 5 years. This is a general slide on the risk factors for mortality. It's the comorbidities that cause problems in COVID. So, and most of us are kind of stressed out physicians. We do carry comorbidities, so it's important to take basic precautions. And Atul Gawande, he works in Boston, and he in Mass General Hospital, they did these 4 things, and none of their healthcare providers had been infected with COVID. First is hygiene measures. I mean, hand washing is a basic thing in medicine in general. We should hand wash even with or without COVID in between every patient. We don't necessarily do that, but that's important, hand washing. Gloves are okay, patient specific, but you cannot walk around in hospital with gloves on your hands. You're just going to carry infective pathogens from one area to another area. Screening is important. Temperature screening, questions, were you visited in the last 14 days? Do you have any other symptoms of COVID, COVID dose, diarrhea? Distancing is important. We divide patient contact into 2, meaningful and non-meaningful contact. And non-meaningful contact is 3 to 4 feet away from the patient for less than 15 minutes. So if you can distance at least 4 feet from the patients, it's important to do that. And wearing masks is very important. Now there are 3 types of mask, and there is a lot of confusion about what does what. If you have P95, that protects you and that protects people in front of you. If you have industrial P95, that's P95 with expiration walls, then it's useful to you, but it's not useful to others because your expiration goes out unfiltered. And the surgical mask or cloth mask are basically useful for others. They are not so much useful for you. It will stop about respiratory droplets and about 30–40% of all the viruses. But it's not going to save, it's not going to prevent you from getting infected. It's just going to prevent your respiratory droplets to go away. So it's just going to prevent the respiratory droplets to go to people in front of you. So what PPE should we use? And this is something that our university uses, proper use of PPE. The top one is non-COVID patients, and the bottom one is proven or patients under suspicion for COVID. And as you can see, non-COVID patients, gloves and eye shields and masks are enough for suspected COVID patients or proven COVID patients. You do need all the 5 pieces, including gown, gloves, and N5 respirator, P95 respirator, and all those things. What has changed? We started doing elective surgeries since April 23rd here. So before that, we were just doing emergency operations, and we were doing virtual consults. But we started doing elective surgeries from April 23rd, and now almost it is May and June, so almost 2 months. So what had changed? In pre-op, we don't test everyone for COVID-19. Basically, because access is difficult. Secondly, my patients are elderly. If I send them to a COVID testing center, they can pick up disease from there. So it doesn't make sense sending patients or exposing them to a risk of catching COVID. So only test patients who are going to have eye operations, ENT operations, pulmonary, as well as GI endoscopy, in neurosurgery, any transnasal, transoral operations. And the patient has been in nursing home, which are care homes primarily in Western countries, not so much in India. But if the patient has been in nursing home, because 60% of nursing home people have been testing positive, so we will test those patients. Otherwise, all other patients, we do not test for COVID. One of the things that I look at, it's not scientific, but in pre-op testing, if someone gets only isolated lymphopenia on WBC count is normal, but lymphocyte count is very, very low, I'll sometimes get those patients tested before surgery because everyone undergoes pre-op testing. And WBC, PT, PTT, INR, everyone undergoes that. And one of the things of any kind of respiratory viral infection, more so COVID, is a relative lymphopenia or isolated lymphopenia. So if lymphocytes are low, I'll get those patients tested for COVID. We ask the patient to quarantine for 7 days with temperature record, morning and afternoon. We consent the patients that when they come for surgery, because of the prevailing cross-infection by healthcare providers, there's a very, very small chance that they can get COVID while in hospital. And more than most, it's a prudence that's important. If you have a patient who has black lung, a lot of respiratory problems, diabetic, overweight, elderly, and if his surgery is elective and can wait, it's probably a good idea to wait. I do DBS, and most of these patients have Parkinson's and tremors for lifelong. So patients who want to wait till the prevalence of infection goes down, ask them to wait. So, so what's important is you got to take a pre-op call whether this is a safe time for the patient to have surgery. Intraoperatively, nothing much different. We just take universal precautions. Eye shields were compulsory even before in US in ORs. While touching the patient, you use gloves. Anesthesiologists use intubation tents because when you intubate the patient, there is aerosolizing of respiratory viruses. So they use the intubation tents. Some hospitals are turning off their laminar airflow for the time of intubation, but we don't do that. So that's the only difference. Otherwise, the surgery is done exactly the way we used to do before. Post-operatively, nothing different. Hospital stays minimum. Most of our patients used to go home the same day or next day. We still do that. We don't allow any visitors. It's all on phone. Everyone stays outside the hospital except for the patient. So that's basically the difference. One of the research projects that we are doing is sympathetic ganglion block, and I didn't want to talk on it, but I want to tell you the basic pathology that we have understood of COVID. Primarily, it's sympathetic overdrive. Sympathetic system goes in overdrive. And because of the sympathetic overdrive, there is vasoconstriction. There is a secondary cytokine storm that happens in the lungs. At the same time, there is pan inflammation of the body, and that activates and mobilizes the macrophages. And because adipose tissue has more macrophages in obese patients, there is much stronger cytokine storm. And the third and most important thing is intravascular coagulation. This is one of the basic features of COVID, and that's what kills COVID patients. All the pulmonary vessels, they undergo coagulation. Renal vessels undergo coagulation. That's why you get acute renal failure. COVID toes, leg amputations, it's because of end arterial block. We see thalamic infarcts also because of deep thalamic arteries getting coagulated. So intravascular coagulation is one of the hallmark of this COVID infection. And that's why it's important not to keep these patients dry, keep them hydrated, start them on anticoagulation, all those things. But that's a topic for another talk, and I think I'll just stop here. I think that's what Amit wanted me to talk about. Thanks.
Thank you, sir, for your nice presentation. Very useful. So, sir, just one question. I will go to Dr. Sisir Das. Now he's in the discussion panel. That, sir, what is your opinion? What you are doing in your institute as a head of the neurosurgery? What protocol you are following for transoral and transnasal surgery?
Amit, ever since COVID started in our country, like end of the March, 22nd or 24th, we haven't done any endonasal surgery. Because our ENT guys, they are so scared, they are not coming out from home.
Yeah. Sir, in your institute, do you test routinely all patients for COVID RT-PCR?
COVID, all free of patient, that means routine patient to get free of COVID, and then we get them followed by routine surgery. Emergency, it's all emergency. So with that thing, we have to wear the PPE and all, as if like they have a COVID and we go for surgery for emergency. But a routine, we do all the routine COVID tests for patients.
So if any patient, sir, in a pituitary, suppose a patient presenting with a pituitary apoplexy where the vision is in danger situation and is a
For me,
confirmed COVID positive. So in that case, what you will do, sir? We can't wait. So will you do transcranial surgery for this patient, or you will still go for transnasal?
good questions. But if I don't get my ENT colleague along with me, then I had to do something like life-saving or the transcranial, or even without ENT colleague, I can go in even. But so normally, any transcranial procedure, we do go with by ENT colleague. But otherwise also, I can go in. It's not if they're scared enough or whatever. But any pituitary these days, I'm capable of doing transnasal when endoscopically. I prefer instead of going craniotomy. But it's not all the same. That you go by transnasal in a patient on the pituitary. There is no risk. But if you do transcranial, there will be more risk. Nothing like that. When you do craniotomy also, there is a lot of dust and all coming. So that's why also a lot of drilling also comes in that way.
Yeah. So now I will go to Dr. Neetu Das. Dr. Das, in your institute, what is your opinion about, as Sir said, that he is not doing routine COVID RT-PCR test. So
Yeah.
Professor Milind does neuromodulation, the deep brain stimulation. Maybe those kind of procedures can wait a little bit. That is the elective procedures. But a patient like a pituitary apoplexy or a pituitary tumor where we can't wait for a long time, in those sort of cases, what will be your advice?
Yeah. Actually, in our institute, recently in our city, Guwahati, the number of cases is increasing day by day. So most of the cases are asymptomatic carrier. But important thing is that we have to isolate the case from the board staff and the surgeon. So routinely, we are starting doing the COVID test in all patients who are going to operate. The aim is that actually, suppose patient coming, we are taking the precaution, all things. Till now, the all patients coming is negative, but we think that if patient coming positive, then we will going to open a complete separate OT and ICU staff for a COVID patient if surgery is required in emergency basis. Regarding the transnasal surgery, I think at present, I think we should avoid, if it is possible, transnasal surgery as well as transoral surgery and awake craniotomy if it is avoidable situation. Suppose if we're going to a craniotomy, sometimes the surgery, usually I do the vascular surgery, especially I do the bypass surgery in the moya disease. It takes a long time. It's 7 to 8 hours is required. What I do, I start the surgery in the early morning and I take a break in between in 3 hours. And I take the between 3 hours and it will relax the mind as well as it will decrease the exposure also. And for the surgeons actually and for the staff, I told that because there is no vaccine is available till present, but we have to increase our body immunity. This is the main thing of treatment, I think, at present for every staff as well as the neurosurgeons. For emergency surgery, obviously, we do the COVID test, but we don't wait for the COVID test. But we perform the emergency surgery. Usually I perform to do this craniotomy, taking the all universal precaution as Dr. Milind said.
Yeah, thank you. And I'll go to again Professor Milind Deogaonkar. Sir, in your institute, what is the protocol for transoral and nasal endoscopic or endoscopy skull-based surgery if it is COVID positive? Are they converting the procedure to a transcranial, or they're using a kind of PA-PR kind of thing?
Well, as I said, all ENT and transnasal, transoral procedures undergo COVID testing. As far as I know, we haven't faced this dilemma as yet. But if we do, then as I said, prudence is important. I mean, you got to weigh healthcare providers getting infected is not a good idea. I mean, you as a healthcare provider take care of so many patients. So in that case, if it's a pituitary apoplexy and you can start them on steroids and maybe go subtemporally decompress. But in someone who is COVID positive, maybe symptomatic, maybe asymptomatic, going through nose is probably not such a good idea at this point. It's always better to take things safe. It's always better to give respect to something which is bigger than us. We just cannot be smart and then, well, we'll do it this way and we'll not get infected. No, this is a pandemic. This is a once in a lifetime thing. You got to give enough respect to the virus and to the disease and just take a few steps back.
Yeah, okay, thank you, sir. So now we'll go into the next presentation to Professor Bin Su. Professor Bin Su, can you hear us? Professor Bin Su? Yeah.
Yeah, he's here.
Yeah. So can you see the screen?
Yeah, we can see. Just go to a. Yeah, that's right. Yes.
Okay, thank you, dear colleagues. So my topic is change of neurosurgical planning during the COVID-19 pandemic and the endemic era. This is difficult for me because it's not our specialty. So I asked Professor Lu Hongzhou, who is a chief of Shanghai Public Health Clinic Center, and he gave me a lot of data, so then I can finish this topic. So I come from Huashan Hospital. So Huashan Neurosurgical Department is one of the biggest one in China. Last year we have 18,000 operations in last year. So we have 4 campuses. This picture is West Campus. Totally we have around 800 beds, 40 operation rooms. From March 8th, we reopened the department, and now it's fully recovered. So this is a coronavirus. This is the epidemic of COVID-19 in China. So we can see the blue columns are the local cases, and the red ones are the imported cases. So until now, the local cases is around 83,000, and the cumulated death is around 5,000. And now, in recent 3 days, we have some cases in Beijing, in a fish market. So now Beijing, some district of the Beijing was shut down again. So we have a lot of lessons because China is the first country to fight the virus. So the whole country was divided into 3 different risk areas, which is a low risk area, middle risk area, and the high risk area. So in the high risk area, we stop local transmission and prevention exportation and implement strict measures. So because we are fighting the virus, so we have the different versions regarding to the diagnosis and the treatment protocols and the prevention and the control protocols. So now you can see the diagnosis and the treatment protocol, we already have 7 versions. And the prevention and the control protocol, we have 6 versions. So this is the traditional containment measures: screening and isolation of cases, quarantine of contacts, and then the suspending public transportation for Wuhan, early and exist screening, and the infection prevention and control, the environment measurement, and the social mobilization control, and the personal protective measures and the social distancing. So I think you are all doctors, so you can understand everything. So the case management, if the patient is suspected cases, they should be isolated in a single room. If the patient is confirmed cases under the asymptomatic infection, could be isolated in the same room. Not after the treatment, the discharged cases will be given isolation and health monitoring for more 14 days, and encourage a follow-up observation and respiratory specimen testing. The contact tracing is also very important. So it needs multiple department cooperation under leadership of local response headquarters, including customs, railway, civil aviation, and other departments. So because we need a lot of this kind of messages to control the contact. And the epidemiology investigators is also very important. So they are responsible for organizing and tracing the close contacts. So the contact management is also very important. The quarantine either at home or at a designated place like hotel. The duration normally is 14 days, but actually now we see some cases it's even longer. We also find some cases for more than 28 days. So the temperature and the symptom are monitored twice a day by individual themselves or reported to a supervisor. So no outdoor activity is allowed. Daily living allowance and the supplies are provided by local community. Mask wearing is very important. Not only protect yourself, but also protect others. So wearing a mask based on risk assessment for general public, no need in general, especially at home or in open areas. But we need wearing a surgical mask when gathering in an elevator or public vehicle, face-to-face interact or high-risk area. For occupational exposure, just like Milind, Professor Milind introduced, we use N95 for health professionals and the surgical masks for others. So the whole country was divided into 4 defense lines. The first line is Wuhan and the Hubei province. The second line is Beijing. The third line is Hubei's surrounding region. And the fourth line is the nationwide, the other province. So we recommended the 4 early detection or reporting and isolation and the treatment. This is very important to control the pandemic. And the community engagement is also very important. We also did a lot of educations and the community hygiene and the disinfections. So other things like resource allocation, logistic support, and the public understanding and the infodemic response is also very important. So this is a proactive defense strategy. We call it dance with the virus. Strict prevention, importation, and the community reassurance. So we control the strategy for imported cases and the tailored control measures at varied risk level. For early measures in new situation, strengthen case reporting and surveillance, enhance the laboratory test capacity in county level, and maintain graded community prevention and control measures. Now, most of the province already resumed the production and the work for almost 2 months. So the control the virus is still very even more important than the shutdown period. So the control strategy for imported case is for now is extremely important because like the Beijing's new case, it looks like the virus come from Europe. So the whole chain management from border to community to home, now it looks like not only the people, but also some goods imported from other countries. So the early screening, the entry screening, and the 40 days history and the health status reporting. And we use a temperature screening and the 4 category of persons according to their different risks: confirmed case, suspicious case, person with fever, and close contacts. So this kind of patient or some close contact with a medical examination for all of these people, and then transfer them to designated hospitals or hotels for quarantine or treatment. So now we already resumed our work for more than 3 months. We reopened the hospital at March 8th, so it's more than 3 months. So this is our health code. We needed to come back to our daily work. So this is green, means safe. So the health code and the travel card is a very, very important to allow you come back to work. And the point-to-point labor cooperation, we organized the migrant workers to return work in an ordered manner through cross regions, point-to-point labor cooperation. So make sure there's no chance to contact some patients or suspicious patients. So in neurosurgical practice, reduce outpatient activity of non-emergency and chronic disease in neurosurgery. This is our East Campus. You can see the security guy stand at the door of the hospital, and all the patients they have appointment, and they need the health card, and when they enter the hospital, they need to taste the temperature and some sterilizing. And this is another hospital. You can see when they come into the hospital, there's some procedure to prevent the epidemic. So for patients in urgent need of admission, they must be ruled out NCP infection. For patients with a confirmed or highly suspicious NCP infection who must be admitted to the hospital, they should report to the supervisor of the hospital quickly. For patients with open cranius cerebral injury in the emergency department, the emergency treatment should be treated at the emergency room. Then they transfer to the operation room with strict protective method. So the patients in the hospital are classified into 3 levels of ward according to the degree of risk. They must be managed in the strict accordance with the regulation of the hospital. They can't walk out the door, do not gather, wear masks, and do personal protection. The unnecessary visits are prohibited. The patient's daily meal are uniformly allocated by the hospital. Once the patient is diagnosed with NCP infection, they should be isolated immediately and reported to the relevant departments. So the people who have been direct or indirect contact with the patient, including the medical staff, should be isolated and observed normally for 14 days. Patients who don't need brain surgery emergently transfer to the designated hospital for treatment in strict accordance with NCP-infected patient procedures. If the patient needs brain surgery, the operating room and the single isolation ward are strictly in accordance with the 3-level protection protocols. So this is a 3-level protection for the doctors. So this video shows the protection of the in the NCP patients' wards. So this is a positive pressure tunnel. UV. This is a treatment ward. So the nurse, normally they work 4 hours in the ward, then transfer to the next personnel. So this is a 3 layers protection. So you can see the very strict protected. So even in the most serious ICU, our doctors and the nurses have 0 infected. So the ward management, health education of the inpatient and the accompanying persons So the mask should be worn in the ward. NCP protection knowledge is posted in the public column. All wards are strictly tried to be implement a layered management system, which is divided into 3 levels of ward according to the degree of risk. That is general ward, suspected patient isolation ward, and confirmed patient single isolation ward. So maintain the air circulation in the ward and ensure ventilation 2 or 3 times a day for no less than 30 minutes. Important items in the ward, such as door handles, bed edge, window stair, or seals, or wall switches, etc., are cleaned and disinfected regularly every 2 hours. So this is a personal protective measures in operating room. So this is in the video of the operating room. You can see the doctors were protected very well, 3 layers. And the nurse, actually this is a negative pressure operating room. So every patient was treated very well. And every doctors or nurses contacted the patients was all recorded very well. So negative pressure. So every case was make sure there's no infection. Under the operating room management and the disinfection, this is a routine, more serious. And the control stage for office and the living areas is also very carefully and regularly. So this is a hand washer. It's sticked to the beside the elevators, and every button of the elevator was covered by the membrane, and this membrane was changed every 2 hours and disinfected. So now we treated the virus as a new normal things. So the daily life practice, we still need mask wearing in a close place with dense personnel, and contact with others less than 1 meter, and working in closed public place, medical personnel, everyone should wear masks. And the social distance still keep around the 1 meter line. And the ventilation and the disinfection was regularly. And the health habit, we should have even more strict than the normal. So the disease control and the prevention, it's all much more strict than the normal time. Actually, it's transferred to a new normal methods. So the measure for the key place and the key institutions, it's very strictly disinfected every maybe 2 hours according to the new protocol of the 6 protocols. The population and the medical institution, everything was controlled and monitored very strictly. in case there's some new chain of infection. Now the school and the schools are reopened for the primary school, the middle school, but for universities, there's only a small part of the university was reopened. Most of the middle school and the primary school was reopened. So it's still monitored very strictly. And in communities like this time, in Beijing, there's some still new cases. So the control of the community is also very important. So now we have more and more experience in this PCR testing, and now the testing fee is quite low in China, and the health code is everywhere need. So now we in almost 99%, we reopened the works and the hospitals. Everything was reopening, and but still some high risk areas was protected very well. So now we already have some a lot of articles published by Dr. Lu Hongzhou and his colleagues. So in Shanghai, actually, we have very limited cases. So from the March 8 to now, actually, we already come the normal practice. So there's no special than the pre-pandemic era. So it's almost the same, but in the it's more strictly for the hygiene and the disinfection. So this is Shanghai's public health center. This is Dr. Lu Hongzhou's workplace. And now they have 840 beds and 3,500 square beds underground. They have a P3 and a P4 laboratory. So they are also WHO cooperation center and training facilities. 300 single isolation rooms for emergency use. Okay, that's all. Thank you. Any question?
Thank you, Professor Binsu.
Mm-hmm.
We'll go to Dr. N.K. Das and Dr. Sushit Das for discussion. Do you have any questions, or do you want to ask anything to Professor Binsu? As he said that he is doing risk stratification, low risk, high risk, and moderate risk. So are you all doing in your institute also? And what do you think about it? Because time has come. Hello, everybody is muted, or is Santosh here?
Yeah.
Mr. Santosh? Can you give the gallery view, please?
Yeah, sir, they can unmute themselves. Dr. N.K. Das is already unmuted, sir, he can speak. Dr. Sisir Das, you can unmute yourself.
Dr. Bin, please,
yeah.
Stop your sharing screen, sir.
Yeah. Can you put the gallery?
Yeah.
So, Dr. Das, N.K. Das, can you hear me, Dr. N.K. Das?
Yeah, yes, I'm hearing. Yeah, Dr. Ghosh, yes, I'm hearing.
Yes.
Yes, I'm hearing. Yeah.
So, what is your views
yeah.
in this regard, what Dr. Binsu has presented? the wide view of China, what's happening, because it started from China. So China was the worst hit. So,
Right. For first of all, thank you very much for Professor Binchu for giving a very informative informations, very important informative information regarding the COVID-19. So I want to ask you one question to Dr. Binchu. So the treatment at present of the COVID-19 is mostly supportive treatment. He has given the elaborately described the preventive measurements of the COVID-19. I want to ask him what is about a herd immunity, because this is a viral infection. Invariably, we have to develop the herd immunity to prevent this infection till the vaccine is coming. So any measurement is for the community to improve the herd immunity, because a lot of asymptomatic patients may be present in the China also, as well as in the community. So what will be the precaution? The patient who are not, we are able to diagnose by COVID-19 test, but they are asymptomatic, maybe virus may be present there. So what is the measures we have taken to improve the herd immunity for against COVID-19?
It's a very good question. Actually, everyone wants to know how many, like in the city, there's how many asymptomatic patients exist in the like Wuhan. So now we already checked almost all the citizens of Wuhan. The population is 11 million people lives in Wuhan. So almost everyone was checked. Now we find around only 900 asymptomatic patients. So now they already finished treatment. So it's not so many because it's already treated very well. So actually, the asymptomatic patients was not so many like we thought. So now the city was reopened very well, and already for almost 2 months. So there's no patients outbreak there. This time in Beijing, actually, the patient's virus is come from Europe.
Professor Binchu,
Dr. Das.
Yes.
So as far as the herd immunity is concerned, for getting the herd immunity against a specific pathogen, you need 70% of people infected. At present, countries like Sweden, Iceland, who have done testing of all of their population, all of their citizens. Iceland, Finland, there is less than 1%. In Sweden, where there was no clampdown, the antibodies are present in less than 3%. So even in India, 70% of 120, 150 crores is going to be a lot of patients to get infected to develop herd immunity. And secondly, we know from IgG and IgM antibodies produced against COVID-19 that they don't persist. They don't protect you from a second infection. And that's why vaccine is going to be difficult. Convalescent plasma has not been very effective. In a lot of countries, they've shown convalescent plasma, they thought it will be useful, but those antibodies are not neutralizing antibodies. So overall, whether you will get a sustainable herd immunity against this virus, we don't know.
Yes.
Dr. Milind, sir. Hello.
Yeah.
Sir, what do you do for asymptomatic carriers? In neuromodulation, an elderly person comes to you and for DBS. So you said you are not doing routine testing for RT-PCR. So how do you detect the asymptomatic carriers?
No, we don't. We cannot. The good thing though for us is most of our patients are above 65 and 70. All are old Parkinson's patients, and they have comorbidities. So it's very unlikely that they will have a virus and not show symptoms. It's a good thing or a bad thing, whatever it is. But our patients are patients with comorbidities, older patients. So for us to have as asymptomatic carrier is very, very unlikely. On the top of that, if we have a asymptomatic carrier, we are still taking universal precautions like we should be with every patient even before COVID. We're putting in the face shields and we're putting masks, and we are washing hands, and we're minimizing the patient interaction. We're not allowing the relatives to come in. These are awake surgeries, so there is no question of intubation. We already have a patient is facing the other way around. So, I mean, if we get a symptomatic carrier, of course, we are at higher risk of getting infected. But then so are we while walking in supermarket or going in train or going in plane. So that's the risk that you have to live with.
Yeah. So, sir, when today's pandemic, when we'll go to the endemic for the COVID infection, so do you think patients should be screened for SARS-2 virus, or just to do the procedure as it was before?
It's a question of availability and access. I mean, we in India do HIV of every patient without consent before surgery. Do we need to do that? Is it ethically right? No, but we still do it. So if you have access and you can screen every patient for COVID-19, you should, I guess.
Yes, yes. Right.
That's what my practice, even if during my COVID period, now it's going on. Last month I have operated 40 cases. Almost like try to do every cases in a COVID test. If not, emergency, okay. Think that is a COVID, like you think that is a HIV positive, HIV positive. Same precaution we are taking and we are doing it. But no stopping. You have to do it.
So, will you prioritize the cases, sir? Just like emergency, or if it is elective case, do you think that it should be postponed till it is negative?
That's a good question. Now, lumbar disc biceps brain tumor. Yeah, good. The brain tumor cannot wait. Meningioma can wait, but not the glioma versus metastasis. All that's you have to take it always. But lumbar disc, yes, you can wait. But how long you can wait? COVID is not going to waiting 1 month, 2 months.
Yeah, because in our institute,
Shishir and Amit, when before April 23rd, we were just doing emergency surgeries, and the surgery has to be cleared by a board. And the criteria they used for that, one was life-saving procedures. Second was where the stage of disease is going to get worse. So patients with cancers, and where if you wait, they will spread more. So it's not really a life-saving procedure, but if the stage of disease is going to get worse. Third was where irreversible neurological or musculoskeletal deficits are going to happen. Right. So those were the three things which were considered as emergency procedures.
Yeah, same way we do. But like it's not a routine lumbar disc we are taking up, fixation we are taking up. It's like rupture, aneurysm rupture.
Yeah, it has to be done. It has to be done.
Aneurysm, rupture aneurysm. What are you going to do? You don't have endovascular facilities in your hospital. Or even if there's a limit, it's not like US, it's a very limited facilities in our hospital or concerned city. 1 or 2 guys do. So what are you going to do? You have to take up the surgeries. Even there is this, but only thing aneurysm gives 1 or 2 days getting COVID negative. We are trying to get the COVID reports and then we take up for surgeries.
So when you don't know the status of COVID status of the patients, will you still using PPE, sir? And what kind of PPE, and are you comfortable operating with PPE under microscope?
To be very honest, I haven't used till today the PPE With that, you can't put a microscope and all. It's very
It's
microscope.
very difficult, almost impossible for me to be within the PP and use the microscope because it is very
difficult. It's just, you know, these temperature, and it's just not possible for me. I haven't used even for a single day, although I operated like 70 cases last 2-3 months. 70, 80 cases or 2-3 months my duration was, I do take a risk, which may not be worth, but with PP, I can't use the microscope for full stop.
Okay, sir.
But
I'll go to Professor Binsu. Professor
But
Binsu.
Amit, but you are using PPE. What you normally use, mask and cap and gown, is PPE. So you're not using a hazmat
Yes,
suit
sir,
or a
for
respirator.
high-risk cases, when you know it is COVID positive, then what kind of PPE you are using? So it's just normal, ordinary kind of PPE, or is the highly protective PPE?
Absolutely ordinary kind of PPE.
Okay.
So the one you use for surgical, normal surgeries, you use shoe covers, you use gowns, you use surgical gowns, use cap and eye shields and mask, and that's it. That's what you use. That's good enough to protect you. If you can handle a P95, you use it. But P95, after some time, first of all, it starts fogging your glasses, and that means it's not properly fitting. So you got to make it fit properly.
Absolutely.
Once it fit properly, it's hard to breathe through it. And if it's a critical surgery and you get little tense, everything becomes very difficult. So looking through microscope with P95 becomes difficult. So just wearing a surgical mask is as good as anything. So because now the patient is intubated and the whole breathing is happening through a circuit. So just surgical mask is good.
Yeah, in our department, every patient was tested for the nucleic acid, and they already have more than 14 days normal temperatures, and the lung CT, everything was okay. After make sure there's no infection, then we could do the surgery. So in the operating room, we just use the same regular protective methods. Yeah.
So I have a question to Professor Zhu. So you mentioned that after the discharge of the patients are kept in isolation for 14 days. So I'm asking these questions because it's a very difficult to ensure our patient also. Where the isolations, in hospital or at home?
At home.
At home. And you and how will it ensure by enforcing on something, or patients itself is the isolation?
Normally they were observed in their own home, and you mean the I mean this patient is already finished the treatment in the hospital for the NCP. So this kind of patient still need to observe 2 more weeks in their home.
Yeah.
Okay, thank you, Professor Binsu.
Okay, thank you.
Now I'll go to Dr. Sarkar, Saumitra Sarkar. Dr. Sarkar, you share your slides with us and give some views and thoughts. What's happening in Bangladesh and what change we need to do in neurosurgery department.
So thank you very much, Dr. Amit Kumar Ghosh, the consultant neurosurgeon of AIIMS India, and also I extend my gratitude to Professor Milind from USA, Professor Su from China, and also other colleagues. So thank you very much for your enlightening speeches. So I think the COVID-19 added a new dimension to ongoing and undeclared Third World War. Unlike the First and Second World War, here the enemies are invisible and they can strike anywhere at any time. And the first reported in the China, I think this is December 2019. And WHO reported and is officially declared is a pandemic in March 11. So now I'm sharing in our country, a developing country in Bangladesh, in some slides. So how the change of the neurosurgical planning during COVID endemic and pandemic era, and how it helped in our country. So in Bangladesh, the first confirmed the COVID-19 case in March 8, 2020. And from the 3rd to 14, Bangladesh is the highest number of cases. And currently on the 14th June today, these 87,520 COVID cases have been confirmed. And the number of deaths rising on 1,171. So the data shows this Bangladesh currently crossed the number of cases, crossed the China, as is the 18th most affected nation in the world by the pandemic. So is there a large impact on the, not only on the patients, but also on the caregivers, doctors, nurses, hospitals. That means it does impact on the neurosurgeons and the patients. So as a result, the hospitals have run out of resources to treat the patient. So what is the goal to changing the neurosurgical planning? It's the decrease the number of surgeries and to restore the resources is the very important goal. So we follow that scale by American College of Surgeons on the non-emergent surgical for triage. So it is a 3-tier system depending on the overall health of the patient. Is the scale of elective surgery acuity scale. And the tier 1 is the low acuity, is all we know that is the not life-threatening illness, like carpal tunnel syndrome, benign intracranial tumors, mildly symptomatic degenerative disease, spinal pathology. So its action is the postpone this type of surgery. And tier 2 is the intermediate acuity surgery. This is the not life-threatening at this moment, but for future is the potential morbidity and mortality. So low-grade glioma, unruptured aneurysm, arteriovenous malformations, this type of surgery postponed if possible. And also the high acuity surgery, and these are the non-emergent surgery like malignant brain and spine tumors, brachial plexus injury, chronic subdural hematoma, progressive cervical malady. And this we don't postpone this type of surgery. So it's very important for the COVID patient, the checklist of neurosurgical cases. And we follow the level of urgency of cases, determine the availability of operating room, determine availability of post-operative beds, and we maintain this checklist. And in our setup, we have 2 types of admissions, directly admitted in our department, and also another is the indirect admission from other departments. But prior to the admission, the patients undergo complete thorough medical history, fever testing, and it's very important is the CT scan of chest, CT chest. So before admission, we set this protocol for the we believe that systemic pulmonary computed tomography can help initially assessing the patient. So if before admission we do these investigations, and if the CT chest is positive, we consider it is a COVID positive cases. It is separate COVID ward and the COVID OT. After admission, we go for the RT-PCR because we all know that it's not a rapid test at all. So it takes some time. So it just reinforces the algorithm setup for the diagnosis of suspected cases again. So admitted patients for the emergency cases, which sets in 2 groups, those requires immediate surgical procedure and those require urgent surgery, but we can schedule this surgery. So the emergency surgery indications in our setups, all traumatic cranial and spinal emergencies, intracerebral hemorrhage, acute hydrocephalus, tumor at risk of intracranial hypertension, Cordai-Quine syndrome, spinal cord compression with neurosurgery deficits. So in our setup, because I'm working in a government hospital, so admissions limited to a maximum of 1 patient per any type of cabin, and general neurosurgery ward is minimum 6 feet physical distance of the bed is maintained. So group A patients which needs immediate surgery, we operate in the emergency operating room or casualty OT, and the group B we are scheduled urgent needs surgery, but we scheduled for in a main operation theater which is directly connected to the intensive care unit. So we made discharge early, and the patients followed up by teleconference, and patients' bed and room were then thoroughly sterilized and kept free for at least 24 hours. And during hospitalization, only 1 visitor per patient per day is allowed with protective mask. So very important for the ease of neurosurgeons is the number 1 is the implement of objective stratification of the community viral load. And there is a community, also our country, we started from tomorrow in 3 zones, depending on the viral loads, is the green zone, yellow zone, and red zone. And use of the objective criteria by triage, already we mentioned in the 3-tier systems. And also we comply the government institutional policy and recommendations by teleconference as much as possible. And is the not persons more than 65 years to report to hospital for work, no patient visitors, and also for stop of the scheduled cases. So it's a very short presentation for you. So thank you very much.
Yeah, nice presentation, Dr. Sarkar. You have given the nice picture. Can we go to the gallery view, please? Is Santosh here? Hello.
Sir, please stop sharing. Yeah. Yes.
Yeah. So I'll again go to Dr. Nitu Das and Dr. Sisir Das for discussion that regarding implementing the protocols. What should be in our future of implementing the protocols for elective cases which can wait, sir, for at least 5-6 days? Do you recommend routine RT-PCR testing for all elective cases?
Yes, I'll recommend not only 1, even if are possible for 2 tests for every patient.
Yeah, that's what we are doing. Yeah.
What's happening in our PT, you know that it's very difficult to get even 1 test.
So for us, we do CT chest and then RT-PCR.
Doing CT chest, no HRCT. The report shows that you don't require that HRCT for just to get the COVID and all, because articles we have seen that we used to do beginning with. Now we stop doing all this HRCT, but we do keep our patient in isolation until we see that that COVID report is negative. Till we see the report, that we keep the patient in isolation, because our hospital is a COVID-free hospital. So that's the reason that we keep them in isolation for a day, at least for a day. Or emergency patient, we consider them, they are COVID. We keep them in isolation ICU, and kind of that there till we get the report. We get the report next day, that is brought back in the normal. That's the policy, and I've been doing that.
Yeah. We'll go to Dr. Sahu for next presentation. Dr. Rabi N Sahu. Sir, are you here? Dr. Sahu, please share your thoughts and presentations.
Yes, James can. visible?
Yeah, visible. Please go ahead.
Is it visible? Okay. So, good evening, everybody. First, I wish to have regard from Bin Zhu from China and Dr. Milind from USA. And I had a very short presentation, and most of the speakers have covered most of the topics actually. This is the pandemic time. Just going through the basics of COVID-19. Mostly it is spread by aerosol and droplet. And we have to be careful of the surface contact. The virus stays in various surfaces for longer, maybe on still surfaces for more than 3 days. And some of the reports also suggest that it also spreads by fecal-oral route. And the symptoms are variable from respiratory symptoms like cough, staging, fever, pneumonia, and also it have some systemic disorders like acute hemostasis and other GIC, and also it may have a cytokine storms and other things like acute exertion and other respiratory complications. So these are the things we have to know these things, and the most important part of this pandemic is the prevention and the segregation of contacts and isolation, and take some protective measures. So the protective measures means adequate self-protection and the PPE. The PPE has to not only you have to yourself learn the donning and doffing procedures. You have to teach the almost all of the healthcare workers in a systematic manner, in an organized way, that they should learn how to wear the PPEs, and because you have to break the chain of transmission. It's more important. If you only do the doctors learn to wear the PPEs and not the caregivers, like even the persons who is cleaning the garbage or the biomedical waste management, the people, they have to also, you have to, the hospital must have a policy to teach regularly those people of the importance of wearing the PPEs and all those things. So these are the basic things most of the speakers have covered today. So so far as the government guidelines, I'm in a government sector, and most of the government hospitals have a more or less similar pattern of management criteria or management algorithm. Just like every patient, most of the hospitals in the government sector are non-COVID hospitals. In most of the state also, they have separated COVID hospitals from non-COVID hospitals, number one. And so any patients who are coming to the emergency department, at present, mostly we are dealing with emergencies only, not the routine cases. And only routine cases, as Dr. Sisir or Dr. Saumitra has told, that we are all the routine cases we are delaying basically, unless it is an acute neurological emergencies. And so most of the patients we refer to the EDs rather than to the routine OPDs. And in the ED there is a screening, and then every state has a suspect holding area. Every hospital has a suspect holding area, and that from that holding area, almost as per the ICMR or in various state guidelines, we test all cases actually. We test, but the problem is that the test results takes around 6 to 7 hours. So until that, sometimes the patient may need surgery and or some interventions. In that case, we treat them as a positive case, and maybe we do only specific emergency measures. And of course, around more than 50% cases, they come negative later on, and they can be shifted later wards to the routine wards and in a non-COVID hospital. For few cases, even last 15 days, we admitted one case of AVM, another case of a compressive myelopathy. Both got positive. We have shifted those patients to COVID hospital. And the COVID hospitals have a two-tier system. One, they isolate if the patient is not an emergency, and they keep them for around 14 days if have some minor symptoms, or if they have a facilities to get home isolation, they're sent back with a very guarded tour, and or they treat the patients until it becomes negative. After 2 reports get negative, they send back the patients to the non-COVID hospital again. And if the patients succumbs, we have in Odisha only around less than 10% have died. So all the dead bodies has to be informed to the state authorities. State authorities deal with the bodies, cremation and other formalities. So these are the basic algorithm. I suppose that this is fairly it is happening in all the states in India. And there are certain the ENS guidelines what I've it was proposed 1 month around. We are also working. Most of us are working during the pandemic. All the neurosurgical procedures should be highly standardized to reduce the operating time, and the use of new materials, instruments, and clinical studies should be postponed until the end of the pandemic. And usually, and we are in an academic setup. We prefer not to give nowadays to the students to do some new surgery, something like that. And we are preferring to get senior surgeons or experienced neurosurgeons beyond their learning curve should perform the surgeries to reduce the total exposure time if possible. We usually join after the anesthetist take up the patients and induce and intubated those things, because most of the centers don't have a positive patient OR room. We have only this one of the routine theaters, and because we take only COVID negative cases now, and this is especially important because sometimes you may not know some patients may be asymptomatic also. And but this is as per the ENS guidelines, they sometimes recommend that power air purifying respirator, that is the respiratory the PP suit should have a power air purifying respirator, which is not available in India so far. And this they recommend, but I don't know. We are not doing any nasopharyngeal routes surgery like transcontinental other cases or endonasal or face surgery these days. So this most important is to the anesthesia management. You have to the intubation is the only important aerosol genetic procedure during theaters, and they have the anesthesiologist take a N95 mask and the face shield, and sometimes they have a barrier intubation method they do. And there are the certain areas one has to be careful while the bone drilling. We prefer to have a dry drilling with a copious irrigation and suction during the time. And the diathermic setting has to be kept at minimum. So that the aerosol generation will be less, and the saline irrigation and flushing should be kept to minimum. And sometimes you have to take an appropriate decision regarding whether to do which type of surgery. We should not plan an extensive approach or a difficult approach which takes a little longer time. And well, most of the times we are preferring in emergencies to do a very short and straight procedure rather than a long route of surgery. And most of these procedures we are taking up nowadays with trauma is a neurotrauma, mostly stroke and SAS, some neuro-oncology patients which are really coming up in an acute emergency. And we have done some pain procedure for acute lumbar disc problems. And we also have done some surgery for acute compressive myelopathies. But those are only if the there is a acute neurology the patient is presenting, then we are only taking those cases. So we are now preferring one case we have operated in a non-conventional approach. We didn't perform the transcontinental surgery. Instead, we because the patient was having a deteriorating vision, then we did the surgery through transcranial route, and most of the SH4 patients were coming with rupture cervical. We are referring those cases to the interventional radiologist to do coiling or other things in the spine. In the spine cases, we are doing mostly MIS or minimal invasive spine surgeries, and those cases. Sorry. So these are the routes we can do operation through transcranial route. The PT can be operated that route also, and these are the traditional approaches which we have learned in the earlier time, and we are preferring those rather than the endonasal routes. We are not doing those cases now, and so at the end, the most important part of these things is a personal protective donning and doffing has to be taught to every of the healthcare workers. And there is, as for the ICMR guidelines, we have a general posting to COVID site and all these things. Those personnel who are working on those areas, they have taken some hydroxychloroquine prophylaxis, and we have a self-motivation and distressing works of or conferences inside the hospital. There are various people are involved with those things, and on the off the site, out of the hospital, we are building a part of health so that because we know these are the pandemic time, we have to live with COVID, and things may little worsen later on. So this is the only way we can build up this system. So these are the certain measures we are taking. And this is a very short presentation. I would love to have, take up some questions if possible.
Yeah, thank you, Dr. Sahu. I just have a question to you. You said you are using PAPR. You mentioned PAPR for the
Yes.
COVID positive cases and high risk like transnasal and all that. Are you using it? Is it available in all India institutes?
No, it's not available. It's not available. The PAPR is not available. It is a the European ENS, they're recommending those things. I think Dr. Binzu showed some of the PAPR, they used it. We have used PP for some emergency cases, but as Sisir was telling, the PPs are very horrible to use.
Exactly.
And in that one case, in a head injury case, we have to use a PP in an emergency room. It was a lot of fogging there. The microscope is not possible to use. Only if there are multiple persons are involved, that it's possible. Somebody does the bone walk, somebody joins after that to do the microscope and then goes out. So you have to use multiple exit and entry from the OR, which is again defies the purpose of COVID. So it is not useful. But I think the PAPR is a good model. Maybe it will come in future. I do not know.
Well, paper is basically something, PAPR, we call it paper. That's something that can be locally made. It's a plastic helmet, and there is a little fan inside the helmet. And then there are little slots behind the, there are slots behind that plastic shield, and the air keeps on coming inside the plastic shield, and that's paper. And that sometimes our anesthesiologists use paper all the time. Our ICU guys use paper. We have not done surgery using paper, but that can be locally made. It's disposable, so it's very easy.
Hopefully it will come in future.
Yeah. So now we'll go to the questions what asked by our participants. So I will request Dr. Binsu and Dr. Milind and Dr. Sarkar and also Dr. Rabi Sahu to see the questions what has been asked to the expert panels. So can you please answer those questions? So first questions, what I can see from Bangladesh, Dr. Aminul Islam has asked, what is the precaution for emergency surgery? So, Dr. Sarkar, will you kindly answer that? What is the precaution for emergency surgery? I think we have already covered.
You are muted, Dr. Sarkar. You got to unmute yourself.
Unmute yourself.
Yeah, thank you. In my presentations, we already discussed that for the emergency cases, because RT-PCR take a longer time, so we usually do the CT checks. If it is a CT positive, we consider it is a COVID positive cases. So we take care of these patients in the separate OT and separate ward. But for the negative CT negative cases, we considered as a COVID negative, but after the surgery, we would do the RT-PCR because it's not possible to do the emergency cases for the RT-PCR cases. I think there's a question from Bangladesh. It will be better to answer other than the Bangladesh neurosurgeons here.
Yeah. So, Dr. Sahu,
I'd like to answer.
Yeah.
Actually, one case we have done with the PP, we first, after the screening, if it is a suspect case, we should take all the cases as a positive case. Okay. So the maximum chance of infection is during the intubation and other anesthesia procedure. Usually the anesthesiologist wear the PPs, they intubate, and during the intubate, they take a sample and send it for the RT-PCR during the intubation. And we have done one case, and the rest of the surgeons come with PPA. They operate the case, and patient again goes back to the suspect side. Fortunately, that patient came as negative, but one could test the while inside this surgical theater. And if the result will come around maybe 6 to 7 hours, then after that, until that time, the surgical theater will be closed, and if in case of positive, it will be re-sterilized again. So those things can be done. But if it becomes positive, then patient has to go to the COVID hospital. That is the proper present guidelines.
Yeah, exactly. So we follow the same. We do it standard PPE. We operate emergency cases with standard PPE and then test, and then if positive, go to the COVID hospital, and if negative, then we do. There is a question from our anesthetist, Dr. Ghosh. Dr. Ghosh asked, do we need to set up or get a license for RT-PCR for all hospitals, public or private? So this is probably, Dr. Sahu, what do you think about it? Probably this is the government policies or what?
Actually, we are following the AIIMS guidelines.
Yeah.
The AIIMS guideline says only you have symptoms or the patient comes from a red zone area, then you can test. So it is they are very strict on those things actually, because all the test has to be done on an online platform, and the test result has to be reported to them also. So there was a lot of debate in our hospital also to test all cases. Ultimately, the government circular told that you cannot test all cases. So we are, as per the guidelines are also a little flexible. If the patient comes, one of the criteria shows that if the patient has come from red zone area or have a close contacts with some red zone relative, something like that. So if you tick those option, you can test it. So 90% time if you are admitting the patients, we are testing on those. But you can, if you are not testing those things, you can do the CT, thorax, and all those, check the other parameters.
Yeah. So his next question was, if positive COVID status positive patients, in elective patients who can wait, will you send them to a COVID hospital till they are negative, or will you operate on that patient? So what will be your...
No. As for the guidelines here, yes, as for the guidelines, even around 2 weeks back, one patient of ruptured AVM actually, in fact, it was a stable patient. He became positive. we had to refer the patient to COVID hospital.
Okay.
The COVID hospital has a both isolation facility as a treatment facilities. Ultimately, it was not different hospital; it was a private hospital. They opted for a conservative treatment of that patient. Okay, and that patient was given some Manitin and other things, and all the positive case, if it is found in the screening area, they have to refer to a COVID hospital.
So when you will operate? So when they will be negative or?
Yes.
Yes.
Yes, it is happening in most of the orthopedic side. Patient with fracture, they are coming because they are positive cases. They go back to COVID hospital. They are staying there for 14 days. Coming back after negative 2 test report shows negative, they are again taken back.
Yeah. Is Dr. Binsu is there? Dr. Binsu? Please unmute all the.
Yes. Actually, this kind of condition, we normally transfer them to the designated hospital, and after they recovered, we then we do the operation. But if the patient have some life-threatening condition, we still have we still can do the emergency craniotomy, like I just introduced in my presentation.
Yeah, one.
Hello. Yes.
Sahiba from Dhaka. He has asked regarding performing of a transcranial as an emergency patient who have not diagnosed as a COVID-19. The COVID status unknown and emergency transcranial surgery is required. So what will be your stand on that?
I don't think that you require emergency transcranial surgery.
Will you convert on transcranial or will you just go ahead with standard PP?
If the vision is the only question is a transcranial vision. Vision is going deteriorating, then we'll take care of the. Take
it as a apoplexy, sir.
Apoplexy.
Just, yeah.
We will do that. Even if required, we'll actually convert from transcranial to transcranial depending upon the situation. Actually, see that.
So in a COVID positive patient, will you always do transcranial or will you still try transnasal because transnasal route has a very high viral load?
Again, Amit, it's a transcranial. When it's a positive, it's positive. Transcranial or transnasal doesn't make difference. You take precaution.
So in a positive patient, what kind of precaution? Because the standard PP sometimes fails. We have seen even with PP, people had infection.
I haven't had any experience. You ask Binsu. That's from China, they can tell you better way. But I haven't experienced a positive. I cannot give you the.
What do you think, Professor Binsu, regarding the COVID positive patient with the urgent transcranial surgery requirement? Suppose the apoplexy.
Actually, we don't have this kind of patient yet. I agree with Professor Das that I don't think this there's some emergency case need the transnasal. I think the transcranial is a better choice.
Yeah.
For emergency case, yeah.
Regarding the use of PAPR, what are the cases where you must use the PAPR? Because you have shown a few doctors who are using PAPR in your country. So those, what are the cases? All cases or some high risk cases?
I beg your pardon?
In your presentation, you have shown some doctors are using PAPR, the motorized PP, the air purifier.
It's only it's not used normally. It's only in some NCP infected wards.
Yeah. So what kind of cases, surgical cases, you use it?
Actually, in our department, there's no until now. There's no even one suspicious case because it's all or screened before they admitted to our department. So actually, until now, we don't have the experience to do this kind of operation.
Yeah, okay. I see other questions. Probably we have covered all the answers in the presentation we have covered. And somebody from Dhaka, it's Shaha from Dhaka, who has asked that what are the criteria of case selection. I think we have covered all this. And in emergency, like any complication of the chronic diseases or neuro disorder, no, it's covered already. So I think all the question of the audiences we have covered. So now I will go to Dr.N.K. Das about any comment about all the presentations.
Very nice presentation and good discussion. The one thing is I want to say that in Indian scenario, the mortality rate is almost less than, I think, 4% now. And most of the patient who were treated in the hospital is asymptomatic, not a severe disease. The patient who has got mortality, we have seen that they have associated with some comorbidity, just like diabetes, hypertension, CKD. But regarding the postponing the elective cases, my view is that actually we cannot postpone the all elective cases in Indian scenario because we have very few neurosurgeons here. And we don't know how much the pandemic will go on. It will maybe 2 months or 4 months. So we cannot postpone the elective surgery for 4 months, 6 months like that. We are enthusiastic that we are giving the importance that we are doing the emergency surgery, but we are postponing the elective surgery. The patient, some patient is coming with a, suppose a young patient is coming with a brain tumor, maybe it's a meningioma also. He is coming from the green zone, there is no symptom at all. So I think in such type of selective cases, we should do the elective surgery. We should not postpone the elective surgery in such scenario. Yes, the patient who is getting some red zone, they're coming the high infectious possibility is there. In such cases, we can postpone the elective cases. Otherwise, it is not possible to postpone the elective surgery because we don't know how much the pandemic will run on. I think in the Professor Binchu, they have very well equipped in the hospitals. So they perform all the emergency surgery as well as the elective surgery. But in current scenario in India is like that, except the contaminated zone, the patient who is coming from the red zone, I think we have to take a proper precaution. But the patient who has got a young patient, no symptoms, coming from the green zone, we think we should allow to go the elective surgery.
Yeah, okay. Now I'll go to Professor Milind. Sir, are you there? Please unmute Dr. Milind. Santosh, are you there?
Yeah.
Sir, so what will be your advice for us for the future so that we remain safe in these difficult times because we are probably will face endemic in future. So what will be your advice?
I think just use logic, be rational. I mean, if someone comes with extradural coning, you really don't care what his status is, you operate. Someone comes with, I don't know, so the like pictures he showed, Dr. Sahu showed with fracture dislocation of cervical spine, you'll fix it. I mean, we cannot discuss it case by case. What will you do on the whether you will transpinodal or not? Basically, consider everyone walking through there is COVID positive, and just use like we did in universal precautions time. Just use your hand hygienes. Keep your distance. You put your mask everywhere in the hospital. I mean, simple things. When I grew up, my grandmother used to tell me while coming in the house, wash your hands and feet. Before eating, wash your hands. So just do all those things. I don't think we should be scared that we'll get it. You're more likely to get it outside the hospital than inside the hospital. But that doesn't mean that you should go ahead and do some elective surgery on someone who is coughing and had fever. So use your judgment, but don't be afraid. I mean, as Dr. Das was saying, No, neurosurgeons, you cannot forever keep on postponing
Right.
elective surgeries. So you got to keep all those things. You got to decide case by case, and that's about it. There is also in UK, they had what they are doing is older surgeons, surgeons with issues, comorbidities. They are not letting them do as much of clinical care, and younger surgeons are doing more of clinical care. So maybe you can have policies like that. Again, I think Dr. Sahu said that we're not letting our residents to scrub in cases where we are not sure, elective cases, emergency cases where you're not sure about the COVID. So you got to get all those little things in place and decide case by case. Don't be afraid. Don't unnecessarily postpone things. Don't waste tests because test numbers are limited.
Yes.
And I think Indranil asked whether you can set up a test lab, but you cannot, at least not in India. In US you can, but in India it has to be government licensed lab. So you got to keep all these factors in front of you and just be rational.
Okay, thank you, sir. This was a very nice discussion. I think questions of the audience is also covered. So I will now go to Mr. Deepak Naik for conclusion and the ending of the session.
Yeah. Thank you very much, sir. Very, very relevant topic and galaxy of stars presenting on the topic and very, very interesting discussion have attracted 738 doctors logging in for this webinar from 9 countries, and 43 doctors have logged in from abroad. So thank you so much for such a large logins, and thank you so much for our distinguished speakers, Dr. Milind Deogaonkar, Dr. Bin Su, Dr. R.N. Sahu, Dr. Sisir Das, Dr. Saumitra Sarkar, Dr. N.K. Das, and finally Dr. Amit Kumar Ghosh for putting this all together with such galaxy of stars and on a very, very relevant topic, how you should change of neurosurgical planning during COVID pandemic and endemic era. We, on behalf of Health NU Therapeutics, enjoyed carrying this webinar on such a relevant topic, and thank Dr. Amit Kumar Ghosh for giving us this opportunity. Health NU would like to thank all the audience, all the speakers, and the panel members for this fantastic presentation and discussion. On behalf of Health NU, I would like to thank everybody and request for support to Health NU products. Signing off from Health NU. Health NU is always together, and this particular webinar and all our earlier webinars on neurosurgery are available on DigiNeuro channel of YouTube. So in case you have missed, you want to revisit, it is all available. Today's webinar will be uploaded tomorrow, and about 20 webinars have been already uploaded on DigiNeuro channel of YouTube. Thank you very much. Signing off. Good night to all of you.
Good night, good evening, good morning, sir.
Thank you so much. So nice of you. So nice of you.
Thank you.
Thank you.
Thank you. Thank you.
Thank you. Thank you.
Pleasure.